My name is Dr. Billy Table. I'm a postdoctoral fellow at the Dell Medical School and the Center for Health Communication at the University of Texas at Austin. I'm also the co-director of the CHC think tank. Today, I'm here to talk to you a bit about my work in interpersonal health communication, and I'd like to take a few moments to describe the work I do with the CHC think tank. Then, I plan to spotlight some of my research on difficult conversations and the LGBTQ+ population. And hopefully, whether you're curious about what the heck someone does with a PhD in communication or hungry to learn about queer research, I can answer a few questions today. Okay, great. Wow, interesting title. Some of you may be wondering, what do you mean difficult conversations? Well, we have to start somewhere, don't we? Difficult conversations are characterized by undesirable topics, strong emotions, uncertainty, and risk. They involve communicative situations such as disclosures, breaking bad news, complex problems, conversational dilemmas, as well as coping with the outcomes of these conversations. Undesirable or taboo topics span across a variety of categories: sex, health, dating, race, politics, finances. Let me break this down a little bit more and give some examples. As you saw in Dr. Donovan's definition, difficult conversations involve disclosure, which is a process of revealing information about yourself to others that's not readily known by them. Imagine a conversation where someone comes out of the closet, shares that they had a miscarriage, or discloses their positive STI status. We tend to go from facts to opinions to feelings. Difficult conversations also involve breaking bad news. These are conversations that pertain to a situation where there's a feeling of no hope, a threat to a person's mental or physical well-being, have a risk of upsetting an established lifestyle, or where a message is given that conveys to an individual fewer choices in their life. So imagine a conversation where someone receives a cancer diagnosis or that the treatment that they tried isn't working. Difficult conversations also involve complex problems. These are conversations where there are multiple options or no clear options or time frame for solving a problem. Imagine that you're at the airport and your flight is canceled and they don't have another flight to your destination yet. There would be a few difficult conversations with your travel partners, with the flight desk. Finally, difficult conversations also involve conversational dilemmas. These are conversations in which you need to tell someone something to fulfill a goal of yours, but they may not want or need to have that conversation. An example here is a breakup conversation. You realize you have the goal to break up with someone and they probably won't like that conversation. Hey, most of us have been there. Wait, those examples all sound kind of troubling. Why would you want to study that? Okay, let me explain. After I graduated from UT Austin in 2020, and became the co-director of the think tank at the UT Austin Center for Health Communication, it became pretty clear to me. I learned all about difficult conversations because I like helping people, clinicians, families, find practical, useful communication strategies to make their lives better by improving their relationships. The work I do with the CHC think tank provides communication coaching for clinicians at the Dell Medical School and beyond. Studies have shown that when clinicians gain better communication skills to address difficult or sensitive conversations, they increase their patient satisfaction with their care and decrease their own burnout. And that's pretty cool to me. With my research and coaching with the think tank, I search for evidence-based, empathetic, and effective ways to make communication easier and, well, less difficult for everyone involved. Recently, a nurse practitioner came to us to ask how to better and more empathetically communicate with patients who disclose that they have significant anxiety and dread about their health. The think tank gave them tips on how to convey hope and build trust with their words and manage their own activation of stress. In another context, a surgeon asked us how to ensure patient understanding of treatment options when faced with a complex diagnosis and possible amputation. We taught the surgeon how to use the teach-back method and also how to effectively ask questions about a patient's values and quality of life. In each of these cases, myself and a collective of experts from medicine, social work, nursing, and communication come together and offer practical recommendations, education materials, and tailored messages for these healthcare providers who come to us. My kind of work in health communication is frequently interdisciplinary. We form the think tank to reflect how multiple disciplines are invariably involved in difficult conversations necessary to solve complex patient problems in practice. We recognize that knowledge sharing across disciplines is foundational to effective care. As an interpersonal health communication scholar, my goal is to partner across disciplines and go wherever I'm needed to research, evaluate, or teach communication skills. I'll tell you more about that. So wait, where do queer populations come into your work? I wish I could do my research at a Pride Parade, but there's a lot of work to be done in clinic settings and with doctor-patient relationships. As I was saying before, my goal is to go wherever I am needed to research, evaluate, or teach communication skills, and difficult conversations involving LGBTQ plus gender and sexuality are unfortunately extremely common in clinical settings. As a quick review, the term LGBTQ refers to those individuals who identify as lesbian, gay, bisexual, transgender, queer, and other diverse sexualities and gender identities. Queer is sometimes used as a shorthand umbrella term for this population encompassing non-cisgender, i.e. non-trans, and non-heterosexual identities. For those who are queer, research shows that many healthcare providers are ill-equipped to serve them, and many enact discriminatory behaviors during conversations, if unintentionally so. For LGBTQ patients, the outcomes of this lack of clinician communication competence has critical impact. Patients' understanding of their clinicians' recommendations, their satisfaction with visits, and their commitment to plans of care and overall rates of mortality are tied to their clinicians' ability to effectively communicate. Clinicians need training on the social and medical factors of LGBTQ plus care and how to communicate such knowledge effectively. Learning about these issues would help mitigate some of the aforementioned inequalities and risks. The problem here also comes from clinicians training in and outside of school. Adequate education for health professionals on queer healthcare needs and experiences may remain inconsistent or absent in their formal curriculum and professional spaces. Across reviews of medical and nursing school curricula, content on queer health, if included, is often less than an hour during professional training. Wow, that sounds like a problem. So how did you study it? In my research evaluating health clinics' readiness to serve LGBTQ plus patients, there was a variety of issues that came up that pointed to the need for queer communication competence training. Let me give you a little background. The findings I will discuss emerged from a study I carried out at the request of a clinic. Leadership at the clinic noted that improving LGBTQ plus healthcare was a priority outlined in Health People 2020, a nationwide agenda for improving the health of Americans. The clinic invited my colleagues and I to assess 1, the employees' readiness to provide high quality care for LGBTQ plus patients, and 2, the LGBTQ plus inclusion level of the current clinic environment. The study would provide guidance for the changes to take place within the clinic's large-scale inclusion initiative. After receiving this request, my team discussed research methods. We decided to use both quantitative and qualitative methods to carry out the evaluation. This is sometimes referred to as mixed methods. The basic idea behind mixed methodology is bringing together these methods permits a more complete and integrated view of the data than if you had done only one or the other. Here's a bit of background on our samples. For this study, we sent out surveys to all employees measuring their knowledge, attitudes, and previous experience related to LGBTQ plus health and healthcare, and conducted interviews to ask questions about their perceptions of the clinic environment and their previous experience with queer patients. So what do difficult conversations surrounding LGBTQ plus health competence sound like? To bring it together and answer this question, I'll mostly focus on our interview findings today. To give a meta overview of some of the findings, it might help to go back to that definition of difficult conversations. Those two features, uncertainty and risk, were at the center of their responses. We found that in 34 interviews with clinic employees in a variety of roles, there were tensions between the desire for change and uncertainty about change within this inclusion initiative. Many were uncertain about what to say or how to ask a patient about gender identity or sexual orientation, and many feared backlash or risking alienating patients. When we analyzed these interviews, we noticed tensions or points of contrast or deviation highlighted in how clinic employees felt about the environment or their own abilities. One of these tensions we called preserving competent appearances and knowledge gap awareness. This tension was exemplified by those making lived experience comparisons. Some participants expressed knowledge of queer identities experiences by relating to the experiences of other minority groups, but failed to acknowledge queer health issues as unique and requiring intentional learning and organizational change. By contrast, others acknowledged the struggles and healthcare needs of queer people being unique, even if they weren't sure about what those needs are. For example, when asked about her experience treating LGBTQ plus patients, one clinician responded with description of her work with other populations. She said, This highly troubling and problematic comparison of queer people to individuals who experience human trafficking represents just one of the situations in which comparisons are used to make sense of the queer experience. The provider feels more competent than other providers in discussing sexual orientation and gender identity because of her background in high-risk youth, though later in the interview she mentions that she does not have queer health-specific training. Further, being transgender is not a choice, and to align transgender patients with victims of forced actions or patients coping with substance use disorders implies that their identity needs remediation. In another example, a participant shared that she understood the complications of being a queer person because of her experiences as a woman in a position of leadership. These are just a few of the several instances in which lived experience comparisons were used to preserve participants' competent appearances. By contrast, others expressed awareness that deep knowledge gaps existed in their understanding. For example, a medical assistant shared, another participant, a nurse, reflected on an interaction with a trans patient. Lived experience comparisons shed light on participants' perceptions of their own queer health-related competence. Comparisons of other marginalized groups' experiences as similar to those of queer people illustrate participants' attempt to assert their knowledge and preserve the image of the clinic as a progressive space, whereas others welcome initiative action to increase their competence. This tension demonstrates how the positioning of queer experiences as similar to others can perpetuate discrimination and misunderstandings. Participants in multiple positions demonstrated their gap in knowledge, but those who showed desire to improve were also open to learning how to navigate those conversations better. From our overall analysis of the interviews, we offered two possible explanations for the problematic conflation and knowledge gaps. One, a lack of exposure to and familiarity with queer people, and two, a lack of queer health-focused training. We recommended that in addition to learning about the medical needs of queer individuals, such as PrEP or gender-affirming resources such as hormone therapy or surgery for trans patients, healthcare providers can decrease stigmatizing attitudes and improve their communication through trainings that include role play, simulations, and large group discussions. This study concluded in 2018, and my team was able to give guidance to the clinic on how they can make the clinic more LGBTQ+ inclusive for patients and employees. In future evaluations of queer inclusion in clinical spaces, my team aims to facilitate the rollout of trainings and be able to examine how employees' perspectives change over the course of the initiative. Okay, cool. Now what are you up to? As I mentioned, my work with the Center for Health Communication and the CHC think tank is ongoing. The think tank meets monthly to take on health communication conundrums and offer helpful suggestions on how clinicians can improve their relationships with patients and promote equitable decision-making. As a researcher, I have other studies concluded and ongoing that look at intersectional issues impacting other marginalized identities in mental health, disability, accessibility, social support, and community engagement. I enjoy consulting clinicians and healthcare institutions and hope to develop and execute more trainings and educational tools to improve communication and care. So if you're interested in interpersonal health communication and/or queer populations, I hope you found something illuminating in this talk. Please also take a look at these articles I reference on the screen, some from me and some from other folks I admire. If you're interested to learn more about other facets of these projects, the Center for Health Communication or the CHC think tank, don't hesitate to reach out. Thank you for your time, attention, and scholarship. See you next time.